Good morning, good afternoon, and good evening. Wherever you're joining from, welcome to today's webinar. Today's topic is Heart Health 2, Measuring and Tracking Heart Health. Today, we'll be taking a deep dive on emerging technologies for cardiovascular diseases and how measuring and tracking heart health saves lives, ensures preventive care, and immensely improves post-surgical care. This event is brought to you by Crack the Wellness Code, a program of ICC, India Community Center, North America's largest secular community center for South Asians, serving the community for over 17 years. For those of you who just joined, my name is Praveen Nara. I'm an event coordinator for CWC and Thai Global. I'm the founder and CEO of TechDatas, a digital transformation and custom software development agency. I'd like to thank the people who made this event possible. Co-founders of CWC, Dr. Pankaj Vij, Naren Bakshi, and Somnath Chatterjee. I would also like to thank Raj Desai, CEO of ICC, for giving us this platform. Tonight, we have an awesome panel of experts in the field of heart health. Our main speaker today is Dr. Rahul Sharma, a well-known cardiologist from Stanford. In addition, we also have other speakers, including Dr. Rajesh Samsuri, Yogendra Babra, Ashish Madhur, and Sandeep Shastri. CWC is an ecosystem of entrepreneurs, professionals, and health practitioners dedicated to cracking their wellness code by embracing evidence-based lifestyle, diet, and wellness best practices. CWC offers several programs, both online and offline. You can visit crackthewellnesscode.org/all events and register for the events of your choice. We have events for seniors, youngsters, entrepreneurs, and also for local communities. I'm glad to inform you that since COVID started, we have done more than 100 online events. And this is a huge testimony to our commitment to wellness as a long-term player and dedicated giver to the community. To continue a wellness movement of this magnitude, your generous contributions matter a lot to us. So I invite you to donate generously by visiting crackthewellnesscode.org/donate. By donating, you will not only help us run these programs better for you, but you'll also help us build content and work on digital projects to support you better. CWC, it's a wellness moment. It's not only accelerating with great plans for 2021 and beyond to embrace your needs, whether you are a tech entrepreneur, a professional, senior, youth, health hero, or a wellness champion, we are here for you. It takes just a couple of clicks for you to donate. And on top of that, CWC is part of ICC, which is a nonprofit 501c3 organization. So you'll also get a tax credit for your donations. And we will soon be announcing universal membership platform at CWC in the second quarter of 2021, which is almost here. And we are really excited about that. And as you may already know, we are working on multiple projects and we are looking for volunteer leaders. Saumya, one of my CWC colleagues, is going to provide details on the chat on how you can participate and become a volunteer leader in this community. We will also be offering micro-learning courses in the coming months, so please stay tuned for that. And I'm also happy to inform you that we have built a very strong backend team in India. They're doing a fantastic job in not only uploading the content, videos, newsletter marketing, creating graphics, building apps, and so many more things to serve you guys better. And we are also building a new CWC Wellness Resource Center in India for these activities. And I'm happy to inform you that this event is being offered in collaboration with South Asian Heart Center. So here is the agenda for today. It's a 60-minute webinar. Usually it goes over a few minutes when people have more questions. But first, I'm going to introduce Dr. Rajesh Samsuri to set the stage for today's webinar and speak for a minute or two. I will then invite our key speaker, Dr. Rahul Sharma, who will present for about 15 to 20 minutes. His talk will be followed by other speakers and panelists. And we will have Q&A after the panel presentations. And due to compliance and regulations, I have to show this slide to you based on our legal team's suggestions. So please watch that and read through it. And with that out of the way, let me introduce you to Dr. Rajesh Samsuri. He's an MD with FACC, and he's a leading cardiologist at West Coast Medicine, specializing in treating and managing heart disease, hypertension, and related conditions. I invite him to introduce today's topic and set the stage for further discussion.
Good evening and welcome all. And thank you, Praveen, for the kind introduction. And thank you, CWC, much appreciated. I'm going to give you a little bit of a background of what we're going to do in the first maybe 20 or 30 minutes, and then pass the stage on to our main speaker, Dr. Rahul Sharma, a structural interventionalist from Stanford. My role is to moderate his part of the discussion and ask and answer some questions for you all. I want to kind of take you guys into a different sort of thinking of what heart rhythm disorders do, and the commonest form of a heart rhythm disorder in the elderly patients, what we call atrial fibrillation. Atrial fibrillation affects about an irregular heartbeat associated with an irregular atrium is noted in about maybe 7 or 8% of our seniors, and many of them seek attention with blood thinners. Requirement of blood thinners becomes very, very important. Several of them require further treatments like catheter ablation or giving a shock to the heart to stabilize the heart rhythm. It's a very serious problem and an annoying problem, and it causes risks and other complications. So today, Dr. Sharma is going to talk about new novel treatments. It's actually not so new, it's been evolving, but it's more recently very popularized amongst us cardiologists, where we do what we call occlusion of the left atrium in order to prevent any clots going into the brain. And it's an alternative to taking blood thinners. So Rahul, you're on, and any questions we'll answer as we go. Thank you.
Thank you, Dr. Suri. So let me introduce Dr. Rahul Sharma. Dr. Rahul Sharma, MBBS, FRACP, is a cardiologist and the director of structural interventions at Stanford Healthcare, and a clinical assistant professor at medicine at Stanford University. Dr. Sharma, please take it away.
Thank you so much. And thank you all again for the kind invitation to be back here for my second time in a short few weeks. It's an absolute pleasure and a privilege. And thank you, Dr. Suri, for that kind introduction. So today, I want to talk to you about a few different things. As Praveen mentioned, my role is that I'm a cardiologist, an interventional cardiologist, meaning that I specialize in doing invasive procedures. Although my specialty or subspecialty area of interest is in performing minimally invasive valve repairs, valve replacements, and as Dr. Suri mentioned, placing devices in the heart to minimize the risk of stroke. And so that's what I want to focus on today, and try and share a little bit of a flavor of where we're at now in terms of modern medicine, particularly as it relates to cardiology and some of the offerings that we have at Stanford. So today I want to touch on the basic anatomy of the heart, just to orient everyone to what we'll be talking about. Talk a little bit about atrial fibrillation, which Dr. Suri mentioned is an extremely common condition affecting patients, particularly as they get older, and how we can help prevent strokes with novel devices. The concept of hole in the heart, or a PFO, or patent foramen ovale, and how closing these can also help prevent strokes. And these have been part of recent changes to the guidelines for treatment of these patients. And then finally, to talk about valvular heart disease, which is an extremely common and somewhat under-recognized problem in society, particularly in elderly patients, and talk about how there are a number of alternatives now of minimally invasive approaches compared to traditional open heart surgery. And so just to orient everyone, obviously there are different levels of medical understanding. The heart has 4 main chambers, the 2 upper chambers, the atria, and the 2 bottom chambers, the ventricles. There is the right side of the heart, which you can see here depicted by blue, And that's where all the veins from around the body converge and return blood after the tissues have taken oxygen out of it. They get pumped to the lungs where oxygen is put back into the blood and then returned to the left side of the heart, whereby the heart pumps and squeezes it to the rest of the body, to the brain and all the other vital organs. Now, in addition to all of these four chambers, there are four important valves, just like valves in any sort of plumbing system, which allow the passage of blood forward and, when healthy, prevent the leakage of blood backwards. And those four valves are at the interface of all of the chambers and the large pipes that lead either to the lungs or to the rest of the body. And they are the pulmonic valve, which separates from the right side of the heart going to the lungs, the tricuspid valve, which is between the upper and lower chamber of the right side of the heart, the mitral valve, which is between the upper and lower chambers on the left side of the heart, and the aortic valve, which allows blood to pass through to the rest of the body. And so some of these terms may be familiar to any of you who have either yourself or through family members encountered any disease states of any of these structures. So now the Watchman device is an interesting device. This is for patients with atrial fibrillation. So atrial fibrillation is a very common condition, particularly as patients get older. Those patients that have congestive heart failure, high blood pressure, age over the age of 65, diabetes, and females have a higher risk of developing a stroke when you have atrial fibrillation. This device is called a Watchman device. And there's a new version of this device, which we have at Stanford, which is a device that we implant through a minimally invasive approach through a vein in the leg and attempt to put it into the heart to reduce the risk of stroke. The advantage of this is that once implanted successfully in over 90% of patients, there is no longer a need to take blood thinners in order to prevent the stroke. And that's very important for elderly patients who are at high risk of bleeding, whether it's because of impaired kidneys, because of frequent falls, or simply because of advanced age. So what you see here is this area called the left atrial appendage. And because of low blood flow, blood clots can form in that area. And those blood clots can migrate to the brain and catastrophically cause a stroke. So this procedure is done under general anesthesia, typically under an hour, and the hospital stay is 1 day. In our experience at Stanford, the procedure time is about 30 minutes, and I actually discharge the patients the very same day, so it's a day procedure. I navigate through a little incision in the vein up to the right side of the heart, as you can see here in this animation, and then making a very small hole from the right side of the heart, crossing into the left side of the heart. We advance a catheter over very small wires. So this is in complete contrast to any open heart procedure. Through these little catheters, we're able to navigate into this pouch called the appendage, where a lot of these clots reside. And then very carefully, we place this Watchman device, which you can see there, basically blocks off or occludes that area. The device grows over with the heart's healthy tissue. And what that means is that there's now a mechanical barrier to prevent those clots that form in that area from shooting out and potentially going to the brain and causing a stroke. So you can imagine that this has been a significant advantage for patients. You need to stay on blood thinners for just 6 weeks. And after that, all you need to take is a baby aspirin lifelong. And it's a very safe and effective procedure. So it's been around for a long time, since 2005. There have been multiple clinical trials performed. And in all of these trials, they've had excellent clinical outcomes, excellent safety profiles. As I said, the procedure now takes about 30 minutes in experienced hands, and we're sending all of our patients home the same day. It's successful in over 90% of procedures, and most patients, I would say above 95%, are able to come off their blood thinners after that 6-week period. What about patent foramen ovale, otherwise commonly known as hole in the heart? Well, this is a very common condition. When we're babies inside our mother's fetuses, it's actually normal to have a hole in our heart because our lungs aren't mature. And so we rely on our mother's circulation to provide oxygen to a baby. And so that hole in the heart is actually a protective, appropriate mechanism. Once we're born and our lungs start to mature, that hole should close off. However, in 20% of patients, that doesn't occur. And so you have what is called a patent foramen ovale, or a hole in the heart that remains. Now, it's very common, so 20%, so 1 in 5 people walking around actually have this. In the vast majority of patients, this won't cause any issues at all. And a lot of people don't even know about this. It's an incidental finding. However, under certain conditions, the flow of blood can change such that blood flows through this hole from the right side of the heart into the left side of the heart. Now, why is this a problem? Well, if we develop any sort of clot or foreign material, air, fat, or blood clot on the right side, and it passes through that hole to the left side, remember that left side, when it squeezes, pumps blood to the brain and to all the other tissues. So what can catastrophically happen is some of that foreign material can go to the brain and cause a stroke. Now, previously, if a patient had a stroke with no other cause identified, and in the part of the workup by the doctor, they were found to have a PFO, they were placed on blood thinners in the hope that they wouldn't have a stroke again. If, despite being on blood thinners, they had a recurrent stroke, then the suggestion was to go ahead and close that hole. Well, fortunately, the guidelines have now changed to say that if you have a stroke and there's no other clear cause identified, and the only thing your doctors can find is this hole in the heart, then it is recommended to close that hole. Now, the good news is, again, in experienced hands, this procedure can be done very simply and very effectively in a matter of under 15 minutes. So this particular device is the device that I use in 90% of patients. It's actually done consciously under sedation with just local anesthesia. A wire is placed crossing from the right side through that hole to the left side of the heart. And then a device which consists of 2 discs is placed, one disc on the left side of the hole, pulling back to seal that hole, and then another disc on the right side. This procedure literally takes me between 10 and 15 minutes. As I said, is done under just local anesthetic with mild sedation, and is a day procedure, meaning after resting for a few hours after the procedure, the patient can return home. You remain on 2 blood thinners for a month, and then thereafter, as the device grows in and becomes part of the heart, just a baby aspirin for the rest of your life. And you can see there with that device closing that hole in the heart, no longer can any clots get through that hole, therefore preventing the risk of a recurrent stroke. Moving on to another area which is also important, particularly as patients get older. So there is a gamut of valve disease, as one can imagine. As I mentioned, there are 4 valves in the heart. I'm going to focus on aortic valve disease, just again, to give you a flavor. It would be too exhaustive to go through every valve and every disease, but just as an example, and this applies to all of the valves, valves can either be narrowed or leaky or a combination of both. Perhaps one of the most commonly understood disease states is something called aortic valve stenosis. So the aortic valve, as a reminder, is the valve that leads from the left side of the heart when the heart squeezes and pumps through the aortic valve, and blood goes to the brain and the rest of the body. So it's a very important valve. A healthy aortic valve has 3 components to it, kind of like a Mercedes sign. And these 3 leaflets open to allow blood to go through and then close to prevent blood leaking backwards. Now, what happens over time with age and degeneration of the valve is that calcium builds up on the valve and it becomes very stiff and very restricted. And so you can see here that the valve clearly looks much more diseased compared to the normal healthy tissue. But importantly, the valve, when it's diseased in its restriction, is no longer able to open. And why is that important? Well, it's because when blood tries to be ejected from the heart and pumped around the body, it can no longer be ejected in the same way through this narrowed, restricted valve. And so less blood is going to the rest of the body, and importantly, less oxygen is being delivered to all of the vital organs. And so patients may present with a combination of symptoms, which can include, but not limited to, fatigue, shortness of breath, chest tightness, dizziness, or passing out. And it's a very common condition, particularly in patients above the age of 75. Approximately 8 to 10% of patients may have this disease. Now, previously, open heart surgery was the only way to treat these patients. And as you can imagine, open heart surgery is very invasive. There are a lot of risks associated with it, particularly in elderly patients. And it's associated with a prolonged hospital stay and a prolonged recovery, naturally, when you're cutting through the chest bone. Now, what's been a marvel in modern medicine is to be able to replace a valve through a small incision in the leg with the patient awake, not under general anesthesia, but with sedation. We pass a wire through the diseased valve. We balloon it to help open it up in some instances in case it's very stiff. And then after we balloon it, the valve starts to open up a little bit more. We remove the balloon. And remember, this is all done through the artery in the leg, through an incision that's less than 1/3 of an inch. We then place a brand new valve through a small tube through that small incision in the leg. These valves, there are different types available on the market. This valve that's being depicted in this animation here is the valve that I use in over 90% of my cases. And these valves are crimped down onto a balloon, and that allows us to put it through a very small incision in the artery in the leg more than 95% of the time. So this is truly a remarkable shift from traditional open heart surgery. We manipulate this device over a wire. We do this under X-ray in the cath lab, and we carefully go around the aorta, which is the main artery that leads from the heart, and we very carefully position this valve gently through the diseased valve. So we're not taking away your current valve, but simply placing a new valve within it. And you'll see from this animation, the valve is aligned and it's centered, and we take great care to make sure it's in the right spot. And then what we do is we actually expand this valve after we found ourselves in the right position, and it expands with a balloon, and you'll see the balloon going up shortly. As the balloon expands, this new valve opens up, and in place of the old valve, which has been crushed to the side, you basically now have a brand new functioning valve. Now, these valves are made of a very thin metal frame, and the tissue on them is actually made from heart tissue from either a pig or a cow, depending on the type of valve. We pull the device out, and what you're left with is this tube, which is then pulled out. We simply cinch down a suture to close up that little incision in the groin. We pull out the wire, and you're left with this brand new valve, as good as the day you were born, sitting in there well anchored. And if you remember that picture I showed you, the disease versus the normal valve, you can appreciate that this is a perfectly normal valve. It's not calcified, and it's opening and closing freely. You can imagine that we apply this to all 4 valves for any disease state, whether it's a narrowed valve or a leaking valve. And we have a myriad of different valves we can use depending on the valve state. One of the advantages of coming to a place like Stanford is being a cutting-edge tertiary medical facility. We have access to the latest and greatest in terms of devices, both in terms of devices that are available now, as well as devices that are not available to others, but are available to us as part of clinical trials. Finally, I'll touch on one more common condition, which is a valve condition, and that's mitral regurgitation, or a leaking mitral valve, which is also a very common pathology. Once again, open heart surgery to either repair or replace the valve was traditionally the only modality of choice. Unfortunately, in a group of patients, such as those with heart failure who have a leaking valve, they were at very high risk to have open heart surgery. And so those patients either underwent very high risk surgery or were treated with medications. So this is what a normal heart looks like. That's the blood returning to the left atrium up here from the lungs full of oxygen, passing through the mitral valve to the left ventricle, which then squeezes out the blood full of oxygen through the aorta, allowing it to pass to the rest of the body. So what happens is, over time, as a result of a number of risk factors, whether it's coronary artery disease arising from high blood pressure, high cholesterol, diabetes, or family history, that valve can become diseased, or simply because of age-related degeneration, or because of previous radiation or certain medications. Regardless of the cause, ultimately that valve can itself become degenerated, or the heart muscle can start to stretch and pull on that valve. And what happens is, you can see here in the animation, blood starts to leak backwards, which means instead of all of that oxygen-rich blood going forward into the rest of the body, some of it, and it becomes a problem when a lot of it is going backwards. So the heart's rendered inefficient. And you can see here, these leaflets are not coming together nicely. And so traditionally with surgery, they would do an incision in your chest, they would open up the heart, they would go in there, they would resect a piece of the abnormal leaflet, stitch it in together, and repair the valve. Or if they were unable to repair the valve, they would put a new mitral valve in there and replace the valve, either with a tissue valve or with a mechanical valve, a metal valve that required a patient to be on blood thinners for life. Now, fortunately, this device called the mitral clip was developed. Similar to the transcatheter aortic valve for aortic valve disease, the mitral clip represents a huge step forward in the ability to treat patients who have mitral regurgitation or a leaking mitral valve in a minimally invasive fashion. This procedure is done under general anesthesia through a vein in the leg, again, a small incision less than 1/3 of an inch. We pass a wire through a small hole in the heart from the right side to the left side, because the mitral valve is on the left side. We poke this hole, very small hole across, and then through this hole, we actually deliver this little clip device. And you'll see from the animation that the clip device is very elegant in its design. We do all of this just under X-ray in the catheterization laboratory, just the same place where you would have a regular coronary angiogram. We steer this clip down to that abnormal valve. We orientate it in different ways. So it's almost like a robotic procedure, but we're doing it via human hands, not via a robot. We place the clip over where we think the leak is coming from, and then we advance the clip slowly and carefully, and this is done under echo guidance with a TEE, so that's an esophageal probe that's down while you're asleep, as well as the X-ray screen in front of us. We then try and grab those leaflets and bring them together. And what we're trying to do is reduce that leak by bringing the leaflets together. And we're basically emulating what the surgeons do, except in a minimally invasive, non-open heart procedure. And you can see there, we place the clip in a place where we try and reduce the leak. If we don't like it, we can release it and try again. And we do that as many times as needed to make sure we have a perfect result. This is a highly experienced operator-based procedure, meaning if you're considering having this procedure done, you can see on the left the regurgitation on the leaks being eliminated compared to where you started. This procedure is heavily dependent on expertise. And so I would encourage you for any procedure, but especially a procedure like this, to seek out a center and an operator who has a lot of volume of experience. So I will stop there. This is just a picture of our new, brand new state-of-the-art hospital in Stanford that's been open since last November. All of our structural heart procedures, or the procedures that I just showed you, are performed in this brand new state-of-the-art hospital. Every room is a single room. This hospital had a $2 billion construction, and I can tell you that it resembles the interior of a five-star hotel. At least that's how the patients feel. And so it's really been a pleasure to work there and to welcome patients into such a wonderful facility. And I thank you all for your time.
Thank you so much, Dr. Rahul Sharma. I, in fact, visited that facility multiple times, and I can vouch that it's definitely a five-star hospital, and also has a lot of greenery on one of its floors, which is really, really amazing. It's almost like you're in a park, and having patients go through that when they're sick, be with nature, I think is healing in itself. So that's great. And I also want to say something. Usually, anytime there is a heart procedure, people get really afraid and fearful about it. And your explanations made it so easy to understand what actually happens in a heart procedure, and gives hope and confidence that just because somebody has a heart issue, it is not necessarily life-threatening. So thank you for that. And even like things like hole in a heart, right? I actually heard some stories of babies having a hole in a heart, and I thought that was like a really bad thing to happen. But if 20% of us have that, then probably it's not as scary as it appears. So
very nice and eloquent presentation. I actually have 3 or 4 questions. Well, 3 or 4 from the audience, and perhaps 3 or 4 questions for you that I think may be more specific, but I don't want to get into such very intricate details. Very nicely presented. So first of all, what are the number of seniors, assuming we have 8% of the 80-year-olds that have atrial fibrillation, what percentage of them qualify for the Watchman? That's the first question. And then what percentage are treated successfully? And then if there are any complications of the procedure, I mean, those are things that everybody would want to kind of understand and know. And then I'll get into some other generic questions afterwards.
Absolutely. Great question. So I think the first thing to say is that blood thinners do work in the vast majority of patients, and they work well to prevent strokes. However, that group that you mentioned, those above 80, by virtue of their age, already they're at a higher bleeding risk. Now, if you add in the fact if they're females, if they're small, meaning low body weight, if they have any kidney problems, and if they've had a high risk of recurrent falls, or they're at high risk for fall, they all fall under the umbrella of high bleeding risk. And in those patients, that risk-benefit ratio of the blood thinner starts to shift in towards a higher risk, less benefit. And so I think that group of patients, just as the first group, is great for Watchman. If I say a percentage that are eligible, I would say 40% of patients above 80 who have atrial fibrillation would be off the bat candidates for the Watchman procedure.
Great, thanks. I'm going to basically ask 2 or 3 quick questions because we have several other very eloquent speakers to follow. So I'm not going to take more than 2 more minutes of everybody's time here. And if there are any further questions, please, feel forward to, please feel free to ask any number of questions from the audience or elsewhere. So one thing goes on to the next, which is the aortic stenosis segment that you talked about, which is where the aortic valve, where you said it's really tight. That's also an elderly problem. Perhaps a smaller percentage of elderly patients have that aortic valve problem, and you and I know very well. So question is, how many people and what percentage of people of those aortic valve type valves that are seen in 80s and 90-year-old patients, what percentage qualify for that? And what is the associated comorbidities? And the last question to follow up is, what percentage require pacemakers after that?
Great questions. So I think I would say over the age of 75, about somewhere between 6 and 7% of patients will have aortic stenosis. Now, once we define that degree of narrowing, because it's a spectrum of disease, as severe, and we do that with echocardiograms, as you know, and the presence of symptoms, and any of those symptoms that I mentioned, the shortness of breath, the fatigue, the dizziness, the heart failure symptoms, we know that 50% of those patients with severe symptomatic aortic stenosis, if left untreated, will be dead within 2 years. It's a significant problem. Now, as I said, previously open heart surgery was really the only option, but those patients, by virtue of their age and all the other medical problems, are high risk for open heart surgery, not to mention the invasiveness and the recovery. So I would say 90 to 95% of patients we see with severe symptomatic aortic stenosis are eligible candidates for the less invasive transcatheter aortic valve replacement, which I showed. Pacemakers are a potential risk, and it varies depending on the nature of the device we put in, but also where the valve is positioned, and that's related to operator experience. I position my valves higher on purpose to minimize the risk of pacemaker. In the literature, the risk ranges from 6 to 15 to 20%. I will tell you at Stanford, our risk of pacemakers is less than 5% overall.
Great, thanks. Now there's some folks in the audience that have asked some questions. I'm going to try to address a few, and then I'm going to probably ask, they're generic, they're very interesting questions, and I'll have you answer a few of them.
Sure.
So one of the questions is, well, the first question I'm going to answer last, which is how to keep your heart healthy in old age. And we'll talk about that as a common denominator. But this next question very quickly is, I'm 75 years old, underwent angioplasty or stenting in 2003. I'm still on clopidogrel and aspirin for 17 years. Is it okay? The answer is 1 year of Plavix and aspirin is adequate. From there on, aspirin alone is good enough. So hopefully that answers the question. Rahul, any comments? Yes? Okay. Next question is, how do we know our arteries are blocked? What kind of heart test would you recommend? And what is the there's no single best test. You do an EKG, you do a stress test, you look at other options. And then you eventually, after screening, you can either do a myocardial perfusion imaging, which is a thallium or adenosine-related test or regadenosin-related test, whatever else. And then lastly, you consider a CT angiography or a coronary angiography. Any other points you'd like to make?
No, I would say, and I think I said this last time, is if you are at risk, make sure you have a good cardiologist. It's people like Dr. Suri who know what test to order and when. That's the most important thing you can do, is have a good cardiologist.
Great.
Definitely.
Now there's another question here about, is drinking wine good for health and how much? And then to follow up, why do some cardiac patients drink less water? I'll let you answer those two.
So like most things in moderation, and there's been a lot of literature that has said red wine is good, and there was things saying red wine is bad. I think the truth, like most things, is somewhere in the middle. The healthy recommended amount to drink for an adult male is 2 to 3 drinks, 2 to 3 times per week. Standard drinks, that is, so a glass of wine. And now there is a caveat. If you have an underlying heart condition which is precipitated by alcohol, such as an abnormal rhythm, or you have heart failure, then that doesn't apply to you. And so, it sort of has to be individualized. And then, sorry, the second question, Sam,
was why do we restrict fluids in patients for?
Oh, right. So in certain patients, and this is that group of patients with heart failure, the heart is unable to cope with the same volume of fluid as a normal heart. And so you will be advised by the dietitian, by the nurses, and by the doctors to restrict your fluid intake and also your salt intake in order to limit the strain on the heart and prevent a fluid buildup in your lungs and elsewhere.
Great. Thanks again for all your effort and time and everything else. And Praveen, the floor is yours. And
definitely great questions, and you moderating it makes it much better than me moderating it, because you know exactly what you're talking about as a doctor. So I appreciate all the questions and answers from Dr. Rahul Sharma. And we'll come back, Dr. Sharma, with more questions. Awesome. So next, let me invite Ashish Mathur. Ashish Mathur is the Executive Director and co-founder of South Asian Heart Center, a well-known organization serving our community here in the Bay Area. They had a very interesting and profound journey in helping South Asians for over 15 years now. Ashish will talk first and then invite Sandeep as a use case who has benefited from their services. Ashish, welcome.
Thank you. Thank you, ICC, for giving us the opportunity to talk about our work, and especially in the context of this beautiful presentation of Dr. Rahul Sharma. I'd like to kind of, turn the table a little bit on looking at, different ways. This was one of the questions that was asked as well, is how do we know that our arteries are blocked? And clearly there are a bunch of tests, as Dr. Suri had indicated. But there are a lot of risk factors that you can look at, and more research has been done to determine what are the exact risk factors that you should look at. One of the things that has emerged in South Asians is because of the twin epidemics of heart disease and diabetes, that this both heart disease and diabetes actually turn out to be metabolic disorders. And as previously thought, okay, diabetes is a risk factor for heart disease. Truly, both of these diseases are happening because of the same reasons. And one of the key issues there is blood glucose regulation, insulin resistance, all of those things that you might have heard about. Today, I wanted to talk to you a little bit about the advancement in the area of continuous glucose monitoring that helps our heart disease patients actually understand how blood glucose regulation occurs and correlate it to the foods that we eat and activities that we do. So with that, I'd like to introduce to you Sandeep Shastri, who's one of our participants at the South Asian Heart Center. Sandeep, I'll just bring up his introduction to you. Sandeep Shastri has been battling with diabetes for the last 11 years and has been involved with the South Asian Heart Center for the last 2 years. This talk that he is going to give, Experiments with Glucose Truths, has been possible because of a device called the Continuous Glucose Monitor. A lot of you may know that, in order to find out what effect of food is on the blood glucose, you would prick yourself multiple times during the day to find out, get a blood sample and then get it tested for blood sugars. But the continuous glucose monitor now has changed all of that and has made it very easy to know how glucose is being absorbed and regulated in the body. So Sandeep has been successfully able to get his diabetes under control, and with that, his heart disease as well. And will be sharing his journey, making the lifestyle changes and leveraging this technology. He's an engineer, an MS, MBA, and works in high tech. He lives in San Ramon with his wife and 2 daughters. Sandeep is passionate about blogging and writes on various topics: personal development, business development, sports, and investing. So Sandeep, take it away.
Yeah, thanks, Ashish. Thank you, ICC, for giving me this opportunity. I'm excited. As many of you all are there, I also am South Asian and Indian from Mumbai. 44 years old. Was diagnosed with diabetes at age 33, and like most people in the Bay Area, it goes unmanaged. I have a genetic. My mom had heart disease. She had a bypass at 41, and also had the other combination of all the other things. As for any heart disease, as doctors say, it's the ABCs. It's the A1C, that is the blood sugar levels, your blood pressure, and your cholesterol. So all those 3 needs to be in check. So for me, as life happens, it was uncontrolled for 10 years. And over 2 years back, I decided that I had to make a change. I was aware of the South Asian Heart Center, and many of us know about it. Like today, you all know about it, but it's about the inertia and taking action. So luckily, I took action in 2019 August. I've been working with Ashish and his team of very able, coaches, and I really thank them in my journey. So the final outcome was, as some of you all, if A1C. If I don't know whether it's basically a continuous glucose. You generally have measured, it's anything below 6 is normal, and anything above 6 is 6.5 is tends to be in a bad range. So I was around 10 when I joined the program, and I decided that I had to try and get it down. And luckily for me, things really turned around, and I was able to make a few lifestyle changes. And within 6 months, I was able to get it. And that's what I'm going to be talking about, the critical success factors, how I leverage technology, and also some of the lifestyle changes. So that's what it is. So what were the critical success factors? So the first one was, I'll be elaborating in each one of them. One is the MEDS lifestyle. So this is something which the South Asian Heart Center advocates, which I'll go into detail. The second thing is the Libre sensor continuous glucose monitoring. So this is something where you can have a sensor. So this is a sensor which I have. It's pretty easy to put, not very complicated. For 14 days, you can check your glucose levels, and then you've got a scanner. So some devices also you can do it on your mobile phone, but I just prefer using the scanner because I get the various charts here instead of going on my mobile. The third thing is journaling, and then the fourth thing is accountability. So I'll be going into each one of this. So what is the MEDS lifestyle? The Heart Center, the South Asian Heart Center, as you know, which has been there in El Camino Hospital, offers services, in Mountain View and all over the US. And now with Zoom, they offer Zoom coaching sessions. So there are 4 things, which is called MEDS. It also can be all for medicines, but there are 4. The acronym MEDS is meditation. So this is something which I have been, consciously doing. In the after, doing pranayam and also doing mantra chanting, which is, I do my Sandhya Vandanam. So this is something doesn't come easily to everybody, but this was something which I didn't start. For the last 6 months, I've been doing it. And then the thing is exercise. So many of us in the Bay Area, at least now, thanks to COVID, we have more time at home and we're not in commutes, we're 2-hour, 3-hour commutes, and we have excuses to go into the gym, and we pay, making all the gyms rich. And now, of course, COVID has changed the business model. So I, in this journey, I decided to get a Peloton, and I was one of the early adopters of Peloton after it shot up after COVID. So, and I kept the Peloton very close to my room. So it, in my bed, near my bedroom, so that I could use that more frequently. Then diet. So the one more thing is diet and exercise. Diet is more vegetables and grains. So they have something called the plate method, and then having restful sleep. So you have you sleep regularly for 7 or 8 hours. So this is what the program entails, and I highly recommend this program, because in order with technology, you need to make a few lifestyle changes, and it's not easy. As I said, for 10 years, I had all excuses. The mind creates a lot of excuses, but sometimes you need that push and that awareness, and that was really helpful. So also, of course, I never gave up on medication, and I had all the medication with a diabetologist, with the endocrinologist. So how do you lose this technology? So as I said, this is a sensor, so you get it through most insurances. It varies. Your copay varies from 25 to 75. So this is again a behavioral thing, because what happens when people generally pricking your finger, that's what traditionally people do, is not, you have to do it in different times of the day, and not everybody likes doing it. I used to get that strip, then the battery goes off, and it was not very easy to do that. So this new sensor is really useful, where you could just put it. It's not too complicated. This takes 1 or 2 days to get used to it, 1 or 2 times, and then you can put it. And then for 14 days, you can track. As you can see your average glucose level for the last 90 days. So I shared this reader with my endocrinologist. As you can see, if I eat ice cream, it goes up. So on an average day, this was my reading, 94/85. So when I started off, it was a little bit higher. So the good thing is, when you eat salads, things are, I know Anita is there, my coach here, and she'll be really happy to see this. And then also my, when you eat ice cream. So it's not that, you totally go on a diet and you only don't eat whatever it is. The good thing about the program is you consciously start eating, you make the right choices. And then I've also been working on intermittent fasting, Ekadasi fasting, because once you get into the improvement, that you realize that, hey, you want to make a few changes, and it is very difficult. So I'm telling you, it takes 10 years. For many people, I can empathize with many people there, but there sometimes you need programs like this which help, and also use technology, because I use these things to check whether whether my sugar levels are going up or sugar levels are going down, and then I make the changes. So it's very easy that way, and that it helps in monitoring long term. So that was one of the things which I have. Then there are other things which I recommend is journaling. This is something where, initially in part of the program, I was first 5 to 6 months, I was journaling, looking at all the what are the grain levels, and we used to do this on a weekly basis. So I used to share all the whatever I was eating. That is also sometimes really difficult, but once you make your have the motivation to do and you want to make the change, you can document it. And then also I had my weight and whatever cardio exercises, my strength training, everything I was documenting. So the good thing is I did this for nearly six months, and I could see my weight go down, and I could track my weight. So which is you definitely feel as an accomplishment. So that is also something which helps. And last thing which I want to talk about is accountability, because many of us, we tend to, when you do it yourself, you tend to cheat. I don't know about y'all, but most people, yeah. So you need to have accountability, and that is where South Asian Art has a excellent coach, has excellent coaches which keep motivating you and help you to monitor yourself. Thanks. Thank you.
That's awesome, Sandeep. Thank you so much for sharing. Yeah, South Asian Heart Center has an amazing program with meds, and I myself learned and followed it and started doing meditation. It's really, really helpful. And your tips on having accountability and journaling really make a difference. And I found that there are two things that we go through. One is we either have a resistance to do something. So for example, when we want to do meditation, there's something that we want to do something else other than the meditation. And I found that if we just start doing it within the first 5 to 10 seconds and overcome that resistance, that helps. And the second thing is to resist the urge. Sometimes we feel like eating that ice cream, right? And that there is an urge to eat. And so if we can resist that urge for a few seconds, sometimes a couple of minutes, that goes away. So I think it all comes down to managing your urges and resistances. So thank you for that. So now I would love to invite our next speaker, Yogendra Babra. Yogendra Babra is the co-founder and CEO of Omnic, a holistic solution for both preventive care and post-surgery care for heart patients. Their in-house solution is currently being rolled out to hospitals for clinical trials. He has also taken the role of coordinating Heart Health Forum at CWC. So thank you, Yogendra. I appreciate you. The stage is yours.
First of all, my thanks to CWC for giving us an opportunity to share our technology. And let me welcome all the participants. Thanks for taking time to join us for this session today. I'd like to introduce, as it's very well said by Praveen, that we have developed a holistic solution for the management and monitoring of patients remotely, with primary focus on the cardiovascular diseases. Cardiovascular diseases contribute about 1/3 of the total deaths worldwide, and two of the challenges that cardiologists face is the post-care management of patients after any procedure they have gone through. About 20% come back to the hospital within first 30 days. And second big challenge is the timely delivery of the care. So what we have a complete holistic solution, which consists of 3 pieces: a device for collecting the body vitals, a mobile device for displaying real-time data, communication purposes, and finally the cloud infrastructure through which we do the data analytics and make the data available to either physicians or anybody who's authorized to monitor remotely. So the key thing is real-time continuous monitoring and analytics of the heart. Without going into too much of detail myself, we have created an animation video that I would like to share with you, and that will give you a complete picture of our solution. So let's get started.
Meet Mrs. Smith. Last week, she had a severe chest pain and was rushed to the emergency room. After a week of care at the hospital, she is now back at home. While her heart health is normal at present, her son Joseph, who lives in another city, is very concerned about her well-being. What if such a situation arises again? This is when her doctor told him about OmniTrack, an easy-to-use wearable ring that continuously monitors a patient's key vitals and makes them available to the doctor in real time. Mrs. Smith notably finds OmniTrack very comfortable and easy to use compared to other devices offered to her in the past. The data from the ring is constantly uploaded and stored in the cloud so that the doctor and the patient's emergency contacts can get real-time updates. In case of an anomaly, alerts in real time are issued to caretakers. These alerts avoid any delay in response and diagnosis, proving to be life-saving for many patients. Joseph can also track progressive developments in his mother's health through a simple dashboard on his phone. Meanwhile, the healthcare providers can monitor multiple patients' overall wellness through an easy-to-use web application. OmniTrack's pioneering technology is providing an entirely new level of safety to patients, assurance to their families, and remote patient management capability to their healthcare providers.
That gave us a good overview of our solution. Just wanted to confirm that the audio was good for the video.
Yes, we were able to hear the audio.
Okay, good. So with that, basically, as I said, that we're focusing on those 2 key elements, post-care management and timely delivery of care through real-time alerts. Our current status is that we are currently conducting clinical trials at 2 hospitals in Bangalore. We expect to get the CDSCO authorization any day now, and we are gearing up for doing our 510K registration in the United States. On long-term, from the long-term perspective, we are structuring a next phase of the trial where we will recruit about 200 patients with myocardial infarction or a cardiac incidence and follow them for about 6 to 9 months for finding potential predictive markers, and hopefully we may be able to predict a little bit in advance through that, and through the real-time alerts we should be able to provide some advanced warnings, then potentially save some lives. On the right hand side, what you are looking at is the accuracy analysis that we have done. We compared our data to a FDA approved device, and we looked at the standard deviation of 5 minutes and 15 minutes between the 2 devices and compared the difference. The difference between our device and FDA approved device is less than 1.5 standard deviation. So we are pretty happy with the accuracy of our device, and the recommendation from our principal investigator is that they are happy. Just to show, this is how the device looks like, and this is the device on my finger. That's pretty much I have from my side to share. If there are any questions I could answer, or we will look at it later on. So with that, thank you everyone for listening to our story.
Thank you, Yogendra Babra, for this wonderful presentation. Definitely having a device that's less invasive would really help adoption and also help these older patients use it more and being cared for when they need help. Let me actually invite Pratyaksha Gandhi.
Thank you, everyone, and very excited to be. This is my first time I'm here with the ICC, and amazing initiative being done. Well, my little bit about my background. I'm a preventive cardiologist, and basically my origins are from Mumbai, India, and I have been mostly into the preventive and the non-invasive side. Really great presentation by Dr. Rahul Sharma. He made all complicated things so very simple with the beautiful videos and the presentation. I think the audience must be very clear that the kind of facilities which are available at Stanford and what he's done is really remarkable. Along with Dr. Sam Suri, we have an amazing team out here, Dr. Mathur, especially I was very much impressed with what Sandeep shared and the MEDS approach being done at South Asian, because my background is that I've been in the forefront of preventing and reversing heart diseases, especially reversing blood pressure, diabetes, and way back in India, all of you know that I'm talking in 1995-97 when I began my practice. I was a hospital owner. People didn't have much of insurance. So I help people without bypass and angioplasty. And I discovered in the journey that lifestyle changes have a massive role to play. So I won't go much into it, but I just really am very much excited about what Yogendra ji has to share about the wearable remote monitoring. That's also is very important. So I just want to thank everyone that amazing moment, and I wish to be part of this, and so more and more with the expertise which I have on preventive heart care. Thank you.
Thank you so much, Pratyaksha. I now invite Dr. Suri to continue with Q&A.
Great, thanks. Thank you again. Pratiksha, wonderful. Pratiksha, where are you based?
I am currently in Los Angeles.
Okay.
Yeah, and I'm doing like lifestyle changes coaching programs, to help people prevent and reverse heart disease. Yeah.
Thank you. So one of the questions that was asked by the same person were, are there any side effects of taking clopidogrel 75 milligrams for a longer period? And my view is there are no major side effects. If you've got other comorbidities, including peripheral vascular disease and such, or cerebrovascular disease, then certainly you can continue Plavix for a lifetime. Rahul, any comments?
No, I completely agree. I think overall there are minimal side effects, and some patients may benefit from long term. But as you said, the absolute requirement is just for 12 months of the clopidogrel and aspirin thereafter.
Right. And another specific question from an anonymous attendee was, I'm 76 years old. I've had 2 MIs, 2 heart attacks. I've had 6 stents, it should say, okay, since last year, and my heart rate is low. In the morning, when I wake up, it's between 48 and 50, and then it sort of goes up to about 60, hovers around there between 59 and 61. I do walk. I don't feel any complications or any such thing, but my wife says my breathing is louder than she can, louder than she can hear it. Can I have a valve problem? So maybe you can address this issue, because it could be an issue of heart failure or maybe chronotropic incompetence.
Yeah. So I think, unless the issue of heart rate, it may be related to the medications your doctor has you on. And in most instances, some of these medications are helpful to the heart. And as part of it, they reduce the heart rate to allow the heart time to fill and make it more efficient. And so unless you're actually feeling symptoms from that low heart rate, it's actually quite reasonable potentially to have a heart rate that's in the high 40s to low 50s. If, however, you're feeling dizzy or lightheaded or tired with that heart rate, then maybe adjustments need to be made to your medication. I think the breathing that your wife may be hearing could be related to extra fluid on board, particularly in the lungs. The other thing to think about is obstructive sleep apnea, which is very common in patients who have cardiovascular disease. And it may be worth raising that when you go to see either your primary care physician or your cardiologist about whether you are at risk for sleep apnea, but also to inquire about your medication dosages and to titrate those accordingly.
Great. I think there's three other questions. Maybe the other speakers can address this. This question might be for Yogendra. Do I need to wear the device for 24 hours? The answer is 24/7. What is the question? I mean, what is the answer?
Well, the idea is you never know when things are, but from our perspective, we want to do an analysis in the real life conditions. So we want to know how is your heart and blood oxygen level in particular, and if you have missing beats, we want to do that analysis. And people talk about heart rate variability, but you as cardiologist, you will agree the true measure of heart rate variability is through the interbeat intervals,
Right.
not change of heart rate over time. So we do that, and essentially based on heart rate variability, other parameters, lifestyle conditions, we develop what we call a heart rate variability index and eventually a heart health score. So longer you wear it, the better it is.
Thank you. I have two questions. These can be addressed by Ashish, I think, and then perhaps if Dr. Rahul Sharma wants to take this on, that would be good. These relate to intermittent fasting, and perhaps Sandeep, you can address one of these issues as well, but I'll start with Ashish. For intermittent fasting, what was the fasting time period and what is best? Ashish, perhaps you can start and Sandeep can address it. And then the other question for Ashish, it's how to reverse blood pressure.
The question on intermittent fasting, I mean, the traditional approach is to kind of get 16 hours of fast and 8 hours of a period in which you eat. And the big question for most people are, is that the 16 hours may span the time period over breakfast, which also is a recommended lifestyle behavior for heart health. So let me have Sandeep answer the question based on his timings, because he actually did it. And then I can come back and talk about how that can be implemented.
Yeah, so intermittent fasting, I did it for some time. I did that, generally made sure that I ate by 8 o'clock. And, because again, the good thing is when you're at home, you're able to control it. Because of COVID, you're at home, you're eating at the regular time. So you can eat finish your meal by 8 o'clock, and then the next you have it by 12 o'clock the next day. So that's the 16 hours. But what I've really found beneficial over the last 1 year is doing the Ekadasi fasting and fasting for, every 2 weeks. And this is again, some might say religious but a lot of our scriptures and Ayurveda, there is always a scientific reason. And there was Ekadashi fasting is generally done every 2 weeks. It's 24 times. And if you look for the scientific reason, there is something called autophagy, which is won by a Nobel Prize winner. A Japanese doctor has won that. So the advantage is for Ekadashi fasting, I generally don't fast completely. I eat sagudana, I avoid grains. And that has really helped me because that is for 24, I avoid eating chapati. I just eat fruits and I'm very disciplined on those days. And there is also a reason because of the moon, the 11th day, Ekadasi is the 11th day of a waxing moon and the waning moon. And there is the gravitational energies of what you eat and the grain. There is a Hare Rama, Hare Krishna explanation for that. But, there is also a medical, if you Google autophagy. So that is something, if some people can't do intermittent fasting, this is something which one can really do it. But again, both work well. Yeah.
I was just going to say that one of the things that we kind of recommend is also to have breakfast daily. So that kind of comes in conflict with the intermittent fasting to some extent in the cycle that Sandeep talked about. But there is a way to kind of do the intermittent fasting where the 8 hours start at breakfast time and then continue till the late afternoon. So if you're able to kind of get your dinner in early by 4 p.m. or something like that, then you can kind of, also incorporate the breakfast, which, from a glucose regulation standpoint becomes a better way of the intermittent fasting. There's a lot of research being done on this right now. People have expressed that they lose weight with intermittent fasting. So we are researching this as well and studying this to see kind of what the impact is and what the new studies are regarding intermittent fasting. And we are hoping that we can do an ICC talk on intermittent fasting, considering that there's so much interest on this particular topic in health as well.
I have one more question. I think this is from Mr. Bakshi. Naren is in Jaipur. Strange, no answers, but all extensive hot tests show me or proof that I'm in great heart health, but my heart rate goes down to the 40s and even as high as the 90s. Is this an athletic heart? Because he's very active, I know. Or am I, and should I use I am on a continuous monitoring chip with Medtronic. So maybe I can take on a little bit of this question, and then Rahul, you can address the other issue about the chip, and then finally Yoginder, maybe I'll get Yog's idea about what this could mean, eventually. And then there's a follow-up question which is unrelated to this. That would be for Rahul. So a question from Naren Bakshi is very valid. I think that he's very well conditioned. He works hard to do this. And Naren, if you're there, please speak for yourself. So this way it'll be very clear. If not, I can answer some of those questions for you. But I think that heart rate variability is a good thing. I think having the Medtronic chip or perhaps any other implantable loop recorder, implantable cardiac monitor to assess for cardiac arrhythmic risk is a reasonable thing, and particularly if somebody is symptomatic, for example, symptomatic palpitations, unexplained syncope, or if people faint in an unexplained way, or if they have had a prior stroke or mini stroke. Those are the indications primarily for this, or after a catheter ablation. Rahul, you might want to address some of the issues of what the indications for ILR or ICM are at this point. Then we'll go to Yog.
Yeah, I think, there's a lot of benefit in, as some may or may not know, there's various levels of monitoring, from the in-hospital bedside EKG, which is just a quick snapshot, to a longer-term monitoring like a Zio patch or a Holter monitor, which can be up to 2 weeks. And then the Link, which is the Medtronic device, the small device that is for longer-term monitoring, is particularly useful because it's small, it's safe, it's very quick, like an outpatient day procedure type situation in 15, 20 minutes, but it gives you up to 3 years. And that's very useful for patients whose symptoms are very infrequent. And so you might not be able to catch it on the day of an EKG or a 2-week period of monitoring in another way. So I think in those sorts of patients where you have infrequent symptoms, it's very useful to try and pick up arrhythmias.
Yog, would you want to address the issue of chip technology for implantable chips versus your non-invasive technology that you are you're certainly done well on?
Yeah, I agree that the longer monitoring is a good thing. So chip is definitely, as long as you can get it, but there are certain constraints and they optimize for power. So I am not sure under all conditions you get it. One of the things is if there is an incidence, the report goes out. Otherwise, once every 1 hour is what you get the report. But I agree that longer monitoring is better, but that's for people who have an advanced diagnosis. For us, using it a wider population, non-invasive, a lot cheaper solution would be able to find larger identification of potential problems. So it's more on a preventive side, so that you can find it before the incidence happens rather than post-incidence.
This might be the last question, and that is it okay or reasonable for folks to take clopidogrel, aspirin, ramipril, and metoprolol, these are medications primarily for cardiac disease, who do Ekadasi fasting? And so Sandeep had talked about Ekadasi fasting. I'm not very familiar with it, but perhaps Sandeep can elaborate a little bit more. But the answer, as far as I'm concerned, is absolutely yes. The question might be, could there be any bleed because of clopidogrel, aspirin when you're fasting? The answer is certainly can, but I think that it's worth. You should not be stopping your medications for one reason or another, and that's the point. Rahul, one quick comment, and then maybe we'll take it to Sandeep about Ekadasi fasting.
Completely agree. Never stop any of your cardiac medications without consulting with your cardiologist. But I'll defer to Sandeep for the intricacies of that fasting modality.
Yeah. So the thing is, the Ekadasi fasting is, the way I do it is I have fruits. Generally, it's not that I'm not eating. I generally avoid grains, rice. So it's just like a discipline. I eat sagudana khichdi. So that is what it is. What the thing is, the autophagy is something. What happens is the way, what the research, the Nobel Prize, there's a Japanese. If you just do autophagy, it's AUTOPHAGY. So Nobel Prize was won in 2016. So what they say generally is that 24 days, they have done research that if you fast for 36 hours and for 24 times, 20 to 24 times a year, you have anti-aging benefits. It has very good benefits. And so what the 36 hours is like, basically your previous night, you sleep at 8 o'clock. And then you sleep, and then the next day you fast, and then you don't eat it. But the Ekadasi fasting, one can't do that. That is, a little bit difficult. What I tend to do is I tend to have only fruits, and I have the sagudana thing, and it works quite well because I also don't do emotional eating those days, because sometimes you're emotionally eating. Since you're at home, you go pick up something. But those days I've become more aware that I don't eat. I'm more disciplined. So that every twice a month it happens. So I do it from a religious perspective, but I don't go with religion completely. I like to understand what it is, and I like to look at medical things also. So I've seen the health benefits. So for each his own. But if you want to know more research on that, the autophagy, Nobel Prize 2016, you Google that, you can get more. And it will be helpful also for both, the medical community and, South Asian art also to look into it and, do more research on that. That's the way I go.
Thanks. Yeah. One short further question, and maybe Rahul and I can take this for like 10 seconds because I think we're running completely out of time, but thanks, we can continue this on a different segment. And that is, my friend has a normal stress test with an abnormal EKG. Is that okay? And Rahul, you might want to just give it a quick shot at it. And there was another question follow up for you, Rahul. So it's normal, abnormal EKG, normal stress test. And then the next question follow up is, I'm an engineer. I marvel the engineering behind deploying devices, but is there any way to minimize intervention?
Okay. So first question, abnormal EKG, normal stress test. Without looking at the EKG, an abnormal EKG can range from the benign abnormal, which is the variation in human health and anatomy, all the way to the abnormal that requires further investigation. A stress test, like any test, is not 100% perfect. And depending on the conditions, we talk about the sensitivity of a test, which is the ability to detect disease. And depending on the nature of the stress test, it can be anywhere from 60 to 85% sensitive, which means it could miss 15 to 40% of disease. That's the short answer. So really, we need a bit more information. But again, have a good cardiologist that goes through your test results with you. Right. The second question about minimally invasive, we are in an exciting era of interventional cardiology where, as you can see, we're now able to replace valves through an incision this big, through an artery or a vein. We are still trying to get smaller and smaller. Of course, modifying lifestyle factors and preventative aspects will help you get into these states. But unfortunately, sometimes, regardless of your best efforts at diet, lifestyle, some of these are not preventable at all. And so you may still end up requiring a procedure. And so I think in the appropriate setting, you shouldn't delay the need for a procedure if indeed it's warranted.
Thank you. Praveen, it's yours.
Awesome. Thank you so much, everyone. Wonderful answers, very engaging conversation, both from the audience and the panelists. I'm really glad that all of you participated so well. And if you guys have any other questions, or if your question has not been answered, we are already going above and beyond the scheduled time. So I invite you to send an email to info@iccwc.org. And one of our support representatives will reach out to you to get your questions answered. And thank you so much again for your participation, enthusiasm, and your awesome questions. The better questions, the more questions we get, the better we are able to answer those questions. And more often than not, one question is not just helping you, but it's also applicable to other people who are in the audience. So it's helpful to the community as well. And again, the panelists, speakers, Dr. Rahul Prakash Sharma, really, really engaging session. Like Pratiksha mentioned, it made the really complex heart related information easy to understand for novices and normal people like us. So that's really helpful. Dr. Rajesh Sam Suri, your coordination and moderation is really, really helpful because you can speak from a doctor's perspective. And thank you for that. Yogendra Babra, Ashish Madhur, Sandeep Shastri, thank you for your participation and sharing your in-depth information. We are really, really grateful for your valuable time and knowledge that we gained. Take care, everyone, and see you guys on the next webinar.